Well, thank you very much. It's a pleasure to join all of you this afternoon for this symposium focused on Baroreflex Activation Therapy for patients with HFrEF. I think this is an incredibly innovative therapy that should be considered by all of you clinically for your patients. But I'm going to set things up for the presentation of data by telling you what the unmet need is here, and why we've got to do more for our heart failure patients. So I think that you are used to seeing slides that look something like this depicting the natural history of heart failure. And when one considers the clinical course of heart failure, there are some patients that are doing well enough, asymptomatic or minimally symptomatic on guideline-directed medical therapies, and there are some patients that are doing so poorly that they may be candidates for advanced therapies such as an LVAD or transplantation. But there's a large group of patients in between who, despite guideline-directed medical therapies, and that includes not only drugs but also other devices such as CRT and ICDs, just aren't doing good enough. Their prognosis remains poor and they remain highly symptomatic, and they need something else. So with significant advancements in drug therapy for HFrEF, do we need a new device in New York Heart Association Class 3 patients? I'm going to answer the question, and I'll show you why. The answer is yes. These patients just desperately need newer and better therapies, newer and better devices to improve their symptoms and ultimately perhaps their clinical outcomes as well. So the opportunities in the management of patients with HFrEF are based on these following observations. One, mortality and heart failure morbidity remain high despite GDMT. We haven't cured heart failure. Exercise capacity remains poor despite guideline-directed medical therapy, and it actually doesn't change very much with GDMT. That is, our drug therapies for heart failure generally don't improve exercise capacity very much. Similarly, quality of life is poor, and it doesn't change much with GDMT, and I'm going to show you some examples of that. And finally, patient tolerance and compliance with GDMT is poor. Yes, maybe we can do better as clinicians, our patients can do better, but the bottom line is that this dream of getting every patient on maximal doses of 4 GDMT agents and some of the other drugs that go along with their comorbidities, really may be unrealistic. And this is where device therapies have an example, because in general, once implanted, everything happens automatically, requiring no patient tolerance or adherence. So, first of all, let's start off here on a positive note and mention that large mortality benefits have been observed across key therapies for the treatment of select patients with HFrEF. You know the medications that work in HFrEF, the foundational drugs that we use to treat HFrEF, and there are also some device therapies that have been shown to reduce mortality and heart failure as well, such as ICD, CRT, and the MitraClip device as examples. But despite the use of all of these therapies, the residual risk still remains high. So here's an example of one study, but there are many that demonstrate, that convey the same message, that in patients who are on all of those foundational drugs, who, if indicated, or have received their primary prevention ICD, or their CRT device, or their MitraClip device, well, they still have a very large residual risk. And if you look at this trial of empagliflozin in HFrEF patients, you will see while it effectively reduced mortality, the residual risk is much greater than the treatment effect of adding empagliflozin to all of those other GDMT approaches. So there really is a large unmet need to further improve morbidity and mortality in our heart failure patients. What about quality of life? Well, the bottom line is that our drug therapies for heart failure have, at best, a very modest effect on improving quality of life. Now, I think it's fair to say that medications such as SGLT2 inhibitors and the ARNI, sacubitril valsartan, have had a major impact on both the treatment of HFrEF and HFpEF as well. But look at the effects of these agents on quality of life using the Kansas City Cardiomyopathy Questionnaire. The between-group difference in quality of life score with the SGLT2 inhibitors is a couple or 3 points. Remember that the validated, clinically meaningful threshold for improvement in the KCCQ is 5 points. So while these findings are statistically significant because the trials are very large, 5,000 or 10,000 patients, the actual magnitude of effect of these drug therapies on quality of life is relatively small. Similarly, they have little impact on exercise capacity. GDMT shows very modest improvements in exercise capacity. Positive inotropes improve exercise capacity. Unfortunately, they kill our heart failure patients. CRT is an option for some patients, being shown to both improve clinical outcomes and exercise capacity, but it is reserved for maybe 15 or 20% of the heart failure population with a wide QRS, particularly a left bundle branch block. So we need better therapies to improve exercise ability in our heart failure patients. And then finally, I mentioned this earlier, but remember, our drug therapies in heart failure are limited by patient access, by patient tolerance, and by patient adherence. And as hard as you try, I'm sure you all have patients in your clinics who only tolerate low doses of beta blockers or ARNIs or an MRA in the treatment of their heart failure. They get hypotensive or develop other limiting side effects, and they just can't, as hard as you try, tolerate full dose 4-drug foundational GDMT for heart failure. So this now leads me to introduce the main topic of this symposium, and that is Baroreflex Activation Therapy, also called barostimulation or Barostim for short. And the way this works is via an implantable neurostimulator device. It's important to note that this is entirely extravascular, unlike a pacemaker or defibrillator where you have leads within the vascular system. This is an entirely extravascular system. It's implanted much like a pacemaker device with a small cut down over the carotid sinus for the placement of the tip of the stimulation lead that's tunneled back to the can. And through that, an electrical impulse can be delivered to the carotid sinus to effect Baroreflex Activation Therapy, to stimulate the high-pressure baroreceptor in the carotid sinus in a way that has been shown to enhance parasympathetic activity, decrease sympathetic activity. Let's call that rebalancing of the autonomic nervous system in a way that would be expected to have beneficial effects on the heart, the kidneys, and the peripheral vasculature. So now the question is, when you apply this approach to patients with heart failure, does it work? Well, there is a trial that you'll hear a lot about today. Maybe you've seen it, maybe you already know about it, called the BEAT-HF trial, which was performed under FDA's Breakthrough Device Program or designation as a 2-phase pre-market, post-market, continuous enrollment, continuous follow-up trial. And so I'm going to share with you just the top-line data from the first phase of BEAT-HF, which ultimately led to FDA regulatory approval. That phase of the study demonstrated at 6 months a marked improvement in exercise capacity. Look at the magnitude of effect here. A 60-meter between-group difference improvement in the 6-minute hall walk. That's about twice what we see with cardiac resynchronization therapy, and more than fourfold greater than what one sees in most effective drug trials for the treatment of heart failure. Here, a 14-point improvement in quality of life score. This is the Minnesota Living with Heart Failure questionnaire, so a negative number is a better number, a better quality of life. A 14-point difference compared to that 1 or 2 or 3-point improvement in quality of life with our established guideline-directed drug therapies for heart failure, and a marked improvement in the proportion of patients who have improved their New York Heart Association functional class status. So, in conclusion, despite contemporary GDMT, significant needs remain in the management of heart failure. We're still not doing well enough. Exercise capacity and quality of life remain poor despite GDMT. Mortality and heart failure morbidity remain high despite GDMT. Patient tolerance and compliance with GDMT is poor. Baroreflex Activation Therapy uniquely works to rebalance sympathetic and parasympathetic branches of the autonomic nervous system. BAT received CE mark in 2014 and FDA approval in 2019, and I think it is gaining good traction in both geographies, and you're next going to hear about the latest and greatest data to support the use of barostimulation as a treatment for heart failure. Thanks for your attention.